Sure, I can start. I want to thank the Office of the Vice President of Health Sciences, specifically Jill. Thank you for helping us organize this series that builds on the series we did last semester. Again, with your help. And last semester we had people, UB faculty that are really involved in patient care, really frontline people. And this semester we're pivoting and we're getting people more involved in policy. We're having anthropologists come in a few weeks and sort of more the story and the trajectory of the opioid epidemic that we're all living through right now. And so this whole series was started because I applied for a HEAL grant, which is Helping End Addiction Long Term initiative through NIH. And as part of that, we have to have people with lived experiences and those that are involved in the real world of the epidemic. And, often as researchers, we're very at arm's length to what we're studying. And so we put together this series to really put a face and a persona to the problem so that us people who are at that arm's length really appreciate what's going on. So we have today Dr. David Holtgrave, who is the Senior Policy Advisor to the Commissioner of the Health at the New York State Department of Health. He's currently largely working and focusing on substance use policy matters, but he has contributed a large contribution to research of the effectiveness and cost effectiveness of a variety of HIV prevention and care interventions. And before he was here in New York State, he was the senior associate director at the White House Office of National Drug Control Policy. And so today he's really going to give us a lot of a lot of information about the trajectory of this epidemic that we're going through. And just to give you a heads up, if no one else asks, I'm going to ask at the end what your prognosis is for us going forward. Okay. So, Dr. Holgrave.
Great. Thank you very much, Dr. Clark, and a great question. And I wanted to thank you and Dr. Shisak for the kind invitation to be part of this and for your partnership with you, Stu, and you, Jill, in planning this session and reviewing drafts and so on. So I just wanted to thank you very much for the hospitality and the honor to be with all of you today. So thank you. And I'm going to start by trying to share my slides, if I might. And see if that works. Let's hope that works.
Yep.
Should.
Working.
Oh,
All good.
excellent. Very good. Very good. So as Dr. Clark said, what I wanted to focus on today was looking at the interface between data systems on substance use and how they can inform policy and program. And previously in academia, when I was at Hopkins and before that at CDC and Emory, I taught a course called Translating Science into Public Health Programs. And it was really all about that interface, not just we have some data, how could we find a program or a policy that it's relevant to, but how can we start with real health department or federal policy and program questions, and what data systems might be best to inform them? So as we go through today, what I'd like to do is touch on about 6 different data sets, but the theme across all of those will be to try and look at how are these relevant to policy? How are these relevant to program decisions that might be able to be made? And just to say in advance, the areas that I'll touch on are fatal drug overdoses. Second, a streamlined set of indicators that we've developed here at the New York State Department of Health that hopefully give a concise look at where the opioid and other drug epidemic is going in the state. Third, the state unintentional drug overdose reporting system, or SUDRS for short, which really looks at the social context in which fatal overdoses occur. Fourth, our work on drug checking and emerging trends in the drug supply. Fifth, a little bit of information about service delivery coverage of the drug user health hubs that are sponsored by New York State Department of Health. And then just to touch on naloxone data just for a moment. And then I really look forward to having a little time before we end on discussion. Happy to answer any questions that you have. Dr. Clark's already asked a great one. But I'd really benefit greatly from learning any feedback you have on these data sets, and also any experiences from the really great work at the University of Buffalo. You all do an amazing job on substance use related research and programs there, and it's so great to get a chance to speak with you and learn from what you're doing. So I hope we have a bit of time to do that at the end as well, too. So just to move on then to these data sets. The first, as I said, is to take a look at the drug overdose data trends. And this is using data from the New York State and city vital statistics systems, which are then given to CDC, which become part of the National Vital Statistics System. So I'll say NVSS for short as we go through these. And this is probably a curve that many of you have seen before. This is the number of fatal drug overdoses over time. Every point on this graph is the number of fatal drug overdoses in the United States for the 12-month period ending at that point. So the very last dot all the way on the right is for the 12-month period ending in December of 24. So all of the year of 2024. So this is always like a lag year that's running. In solid is the actual reported numbers, and the dots are CDC's predicted numbers. They take into account the fact that there's always some underreporting, and they try and make an adjustment for that. So when I look at these, I always look at the dots actually, because CDC knows there's underreporting and they try and adjust for it. Of course, on this slide, the main thing that we see is thankfully that decline from a very rapid period of increase to the point that we're about at pre-pandemic levels in terms of COVID now. And that's really been quite a remarkable drop from 23 to 24. On this next slide, same sort of graph, but now we're looking at New York, rest of state. So this is all of New York outside of New York City. You see a similar trend, and if anything, even more so of a decline over the last year from the height that it was in 2023. This is now for New York City only, not the rest of state. And we see again a decline here in New York City, but not quite as much as we saw for New York State and for the nation overall, but still a very important and pronounced decline. And as we go through these slides, when I look at the decline, one thing I always want to make sure that we're keeping in mind is I think we have to sort of hold in our hearts two things at once. We have to be very glad that there are people at the dinner table in the community, our friends, family, who would have otherwise been lost to fatal overdose that were saved because of this decline. But we still have very much work to do, as you can see by the height of where this curve ends. So this is not a victory lap. This is sort of looking at what are the trends, what do we see? We can be very glad for those lives saved, but we still have much more work to do. And I'm also going to talk about health disparities as we go through the data further as well. Next, I wanted to show the same graph for the US, the state, and the city, but now I'm breaking it out by type of drug. And for the US, the main thing I just wanted to note that on top is all opioids. Next is synthetic opioids other than methadone. So this is really fentanyl by and large. The next line down is psychostimulants with abuse potential. That's largely methamphetamine. And then cocaine is in pink or purple here. And it gives you a general sense of sort of what the trend is. And as you can see, these numbers add up to more than the total. That's because of polysubstance use. So it's possible that if someone experienced a fatal overdose and both fentanyl and cocaine were involved, both would appear on this slide. Now, when we look at New York, rest of state outside of the city, we see a slightly different pattern. Methamphetamine, which was very pronounced, I'll go back I'll go the other day. There we go. Methamphetamine, very pronounced, the third line here in gray. When we look at New York, we don't see that. It's dropped much farther down here. But cocaine seems to be even closer to the fentanyl gold or brown line that you see here. So an interesting difference of patterns for New York State compared to the US. And then if we look at New York City, specifically, also interesting in that cocaine getting fairly close to the fentanyl line here. So a lot of fentanyl and cocaine polysubstance use. But what's interesting is the blue line is heroin. And compared to the nation or rest of state, we see a bit more presence and persistence of heroin in New York City. So I just wanted to quickly touch on that because it's useful to do deep dives, I think, to look at specific jurisdictions and what are we learning about what types of drugs are involved in fatal overdoses. One thing also I just wanted to note is that in 2022, when I was at the White House Office of National Drug Control Policy, um, a national drug control strategy was put forward by the previous administration that had specific goals, one of which was that by 2025, the end of 25, the number of fatal overdoses in the US would be no more than 81,000 per year, which at that time in 2022, that was kind of at the height of the number of fatal overdoses, was seen as really quite a daunting goal. And my colleague, Professor Regina LaBelle, and I did this piece. She's at Georgetown at the O'Neill Institute that we did for their website. The fact is that actually that goal of no more than 81,000 fatal overdoses in the country was met a year early. Instead of being met by the end of 25, it was met by either December of 24 or January of 25, depending on how you look at the numbers and how you do the analysis. But essentially, it was met 1 year early. So that was really an important public health achievement, which seemed very, very difficult when it was set out in 2022. The other thing I just wanted to mention was we did a paper with Commissioner McDonald of the Health Department here in New York. It was recently in Annals of Epi, and this is the first part of the summary table. For the US overall, if we compare fatal overdoses in 24 versus 23, we can see that that accounts for about 29,646 lives saved, over 928,000 years of life saved. And if we look at the Department of Health and Human Services approach to doing regulatory economic analyses, when they say, if you want to value a statistical life saved, looking at values of like 6, 13, or $19 million per life saved, if we take those three approaches here for a low, medium, and high valuation of statistical lives saved, we can see it's from about 180 billion to just over 584 billion. So really tremendous economic impact and import from these lives saved and years of life saved as well. So now I wanted to just finish talking about fatal overdoses by touching on the important area of looking at race and ethnicity. And to get this information, we have to go to another CDC source, and this is Wonder, the wide-ranging online data for epidemiological research database I'm sure many of you are very familiar with. And when we look at race and ethnicity, some of the limitations which Wonder will highlight and which a number of us have seen in the literature is that because race and ethnicity or Hispanic origin are reported separately, how they're coded may or may not be entirely consistent. Hispanic origin might be underreported because it's a separate question. Counts below 10 in cells are suppressed, and that can lead to important implications, for instance, for American Indian and Alaska Native populations. If the number in a cell in these tables goes below 10, it's suppressed. And if there's enough suppression, it can make it look that there isn't a disparity there. Now, so this is a case where you're really balancing privacy, which is incredibly important. We don't want to identify any particular person even inadvertently, but also want to be able to look at the disparities. And I'll come back to this point in a moment. And 2024 data are still provisional at this point. But what does this look like? So this is just output from CDC Wonder. On the left-hand side, this is a graph of the number of deaths by year from 2018 through provisional data for 24 by a variable they call single race 6. It's the racial and ethnic categories that you see here. I should say specifically, it's the racial categories that you see here at the bottom of the page. And when we look at the disparities this way, you can see we have in blue on the top is white, then black are African American, and green is next, and then lower numbers. But on the right-hand side, if we now start looking at rates per 100,000 population, we can see immediately that African American or Black communities rises to the top in rate, white second, and then third is American Indian or Alaskan Native. But you can see what happens in 2024 because in a number of areas, the numbers are so small, they start to get suppressed. And it makes it look like there is no rate in 2024 for Native American communities. And this is a case where the suppression for small numbers sort of gets in the way of identifying a really important disparity. So I think it's key that we keep that in mind as we go through here. So, we want to address the numbers overall, and we want to address the disparities that we see here as well, too. Um, Now, I wanted to shift gears to the second slide set and talk a little bit about a streamlined indicator set that we developed for New York State. There's a lot of indicators, dozens of them on the health department's website, and we wanted to try and give a more snapshot picture. This is the most recent as of May of this year. There's not quite enough to update it yet, but we'll be doing that at some point in the spring. And these are the 8 domains that we choose just for 1 or 2 metrics on each to try and give a sense of what's going on in the state. And you'll see these as we go through. So for fatal drug overdoses for the state of New York, now I'm combining the city and the rest of state together. You can see this decline from 66.88 in 23 to 45.67 in 2024. So see that decline in New York State. But of course, it's one thing to look at fatal overdoses. We want to look at some other domains as well, too. And one important one is non-fatal drug overdoses. And if we look at that, we can get some data for the state from emergency medical services. And we can here in non-fatal overdoses see a little bit of a decline as well from about 26,700 to a little over 21,100. So a bit of a decline, not quite as pronounced as in the prior curve. Um, but just because there's an EMS call, there may be other ways that someone would present at an emergency department, including someone brings them to the emergency department, they present themselves, but also could be via EMS as well. So this is sort of all pathways of someone getting to the emergency department. Again, see a bit of a decline over time, but also not quite as pronounced as in the prior slides. Um, Next, let's shift to hospitalizations. And here you don't see too much of a decline, a little bit from 13,495 to 12,382. And I think what's interesting in the set of slides is you see the biggest decrease in fatal overdoses, and then still the same pattern, but a bit less for non-fatal emergency department visits and hospitalization. So that might be something we want to talk about in the discussion later on. Um, and then we can talk a little bit about treatment coverage. This is just one metric of persons who are enrolled in unique persons who are enrolled in substance use disorder treatment who reported any opioid use as the primary substance at admission, going from 2010 all the way through 2024. So you get a sort of a sense of the number of people who are in treatment in the state. Then next, we can ask a little bit about buprenorphine, an important medicine for its role in drug treatment. And this is the number of people who've received at least one buprenorphine prescription for opioid use disorder in the state. One would hope to see this go up a bit, and it does go up a bit over time. And then the related question is how many people are receiving buprenorphine for treatment for opioid use disorder for 6 months or more. So not just that first prescription, but to have it maintained over time. And you can see here, again, going up a little bit, relatively flat, but a little bit of an increase. The number of persons who are experiencing substance use disorders are really important metrics. So this is a key prevalence number. Um, uh, Sadly, though, the field is a bit challenged in this area. We have to look at the National Survey on Drug Use and Health, or NISDA for short. And then by the time you can break it out by state, a couple of years have usually passed. And so for 21 to 22, for New York State, the estimate was that there were about 1.3 million people with drug use disorder, excluding alcohol. That may change as new data comes in, and this is an important one that we'd really like to have much more up to the minute data. It's a really important data set, but we'd like to have even more timely data on prevalence. Harm reduction coverage, another measure of service delivery. By harm reduction, we really mean in the state that there's a syringe service program, a drug user health hub, one of those that are sponsored by New York State Department of Health. And now within a 30-minute drive, over 90% of the population in New York is within a half-hour drive of a harm reduction site. Of course, if one is experiencing a crisis, that can be a very long drive, but it's one way we're trying to keep track of how many people, what's the relative percent of the population relatively close to a harm reduction site. And I'll show a map of this later as we continue to go through. Um, Another way we can look at key metrics are prescribing of opioids. And of course, one wants to think about proper prescribing of opioids when they're absolutely needed, prescribing of alternatives to opioids, and then alternatives to pain management outside of prescription. So maybe acupuncture, something like that. And there's two metrics that we have kept track of through the New York State Prescription Monitoring Program. This is the number of episodes when someone who is opioid naive gets more than a 7-day initial supply of opioids. And you can see that thankfully this has gone down a bit over time. Since 2020, it's gone from 289,000 or so to 241,000 or so. The exact numbers are always on these slides, of course, but moving in the right direction. And one of the things that we can't quite get to pull out of this is certainly there are cases, maybe with cancer patients, somebody experiencing surgery, where there needs to be a short-term initial supply of opioids. And one would like to be able to back out some of those medical conditions. And that's an important area that would be tell us even more information if we could pull some of those cases out. Um, Also, another way to look at this is not just the length of that initial prescription, but how strong it is. So 90 MME or morphine milligram equivalents is really quite a strong dose of opioids. And so this is looking at prescriptions for 90 MME on more than or at least one day in the state. And again, here you can see a decline going from 2019 of over 210,000 to a little over 141,000 now. So again, moving in the right direction. So those were a grouping of slides, metrics, I should say, that we put together to try and get a quick initial sense of generally where we're at, generally how are we doing in the state of New York if we look at those domains. Now, I wanted to dive into third, the area of the suitors data, and it's, I should say, the state unintentional drug overdose reporting system. I'll just say CDC suitors data for short. And a couple of things to say at the outset here. We always want to make sure the team here in the Office of Drug User Health, the Office of Science, that we really emphasize all the data I've been talking about, all that I will talk about, that every data point represents a human life and the loss of a loved one in the suitors data because we're focusing on fatal overdoses. And we really want to make sure that we're always keeping that in mind, of course, as we go through. The most recent year for a full report from the state of New York is at this QR code on our website. But I wanted to share with you today not just the 23 data, but rather we have now publicly available the first half of 24. And in the suitors data, this is really going to be talking more about the social context in which fatal overdoses occur. So this is New York data, state and city combined. And the data comes from a combination of toxicology reports, medical examiner reports, our coroner reports, and death certificates. And you can see in this slide how much have all of those elements to that, and then a smaller minority have only either a death certificate or a death certificate and a tox report or a coroner or medical examiner's report. So what are these data that do a deep dive on the context in which fatal overdoses occur tell us? Well, the first thing is really that there's a lot of polysubstance use that occurs. So on 75% of fatal overdoses for the first half of 24, fentanyl was present. Cocaine was present on 55%, any stimulant on 64. So you can see these numbers are adding up to way more than 100%, indicating there's a lot of polysubstance use that's going on. And we're starting to get then from this slide a little bit of information, which we'll see more of later, on things that might be adulterants with drugs too, like xylazine, which of course is a veterinary tranquilizer that is increasingly seen use as an adulterant of fentanyl. And when I was at ONDCP, we declared it nationally an emerging threat in the United States. So Suter's data tells us a little bit about drugs that were used, polysubstance use, and adulterants. Could also tell us a little bit more about demographics. So for New York State, first half of 24, the majority of cases were among men. We see this broken out on this slide for men and women, and then broken out by age. And you can see that especially for men, older populations have a higher percentage of fatal overdoses. We'll come back to that in a minute here as well. We can also get some information from suitors about race and ethnicity. About 48% of these data for New York State, first half of 24. For Black non-Hispanic individuals, about 26.5% identifying as Hispanic. And you can see what the breakout looks like on this slide. So we get a little bit more information about communities with higher rates who are relatively underserved. On this slide, we're taking Black non-Hispanic individuals, Hispanic individuals, and white non-Hispanic individuals, and then within each of those columns, breaking out by age. And you can sort of see what does the age breakout look like by each of those three racial and ethnic groups. And for Black men, the age distribution seems to be a fair amount older. And that seems to be true for New York, but also nationally as well. And where we have drug type data that we can overlay with this largely seems to be an impact of cocaine use, not exclusively, but there's a disproportionate impact. So this is an important community to be able to serve adequately to address needs. So Suitors gives us some more information here about differential impacts in different communities. Also, again, talking about social context. So we see from suitors that for New York in this time period, about 63% of people who died of an overdose died at home. And I think people assume that that's not the case without looking at these data. This is generally true in the United States as well, too. Not quite as pronounced, but still generally true. And 23% were seen in an emergency department. 73% had no pulse when first responders arrived, and 24% had been administered naloxone, but perhaps too late after the person had already passed. But where this occurred at home is really important. And 1 in 3 overdose deaths had a bystander nearby. They were either physically at the onset or duration or shortly after an overdose. They were potentially had an opportunity to intervene and to respond. And these are not the first responders or medical professionals who were called, but other bystanders. So this is really important to thinking about from a programmatic and policy perspective. Are we equipping with naloxone and training all of the persons who are bystanders and who could assist? And on this slide, we see there's a number of reasons why someone might not have been able to participate as a bystander. They were in a different room. They didn't know the person was using substances. They didn't know how to recognize the overdose that was occurring. But again, I think it tells us a lot about what kinds of services to help bystanders to be even more equipped to intervene in the case of an overdose. Also, Suitors tells us a little bit about the social determinants of health. So about 9.3% of persons were experiencing unstable housing at the time of their death, and about 5.5% died within a month of being released from an institutional setting like a hospital, jail, or residential treatment facility. And these are really important, I think, to keep in mind that we're ensuring that we have services that are ongoing to these areas as well, too. There's a lot of unmet needs also in terms of services. So 74% of persons who died of an overdose had a documented substance use history in their record, but few had evidence of receiving treatment. 11.2% ever treated for substance use disorder. Despite having a documented history, 74% having a documented history of substance use disorder. So again, lots of room to move here in terms of addressing unmet need. Similarly, for mental health issues, so 23% of persons who died of an overdose were living with a mental health condition at the time of their death. And depression and anxiety disorder being the two topmost that you see here. Bipolar disorder, schizophrenia, also represented here, but a bit smaller numbers. And for physical health, we also can see that persons who died of an overdose, many had at least one medical condition as well that could have required or should have required ongoing clinical care. Heart disease being most among those, 51% of persons having underlying cardiac condition in one way or the other. And you can see what a number of other physical challenges represented here on this slide. So those are a few aspects of the really rich data set that is Suitors. And I want to end in 10 minutes or so that we save time for some discussion. So let me just touch on the other three data sets much, much more briefly now. So one area I just wanted to mention was the area of emerging threats and drug checking programs. So when I say emerging threats, we're really thinking about changes in the drug supply, new drugs, new adulterants, new patterns of use that may occur. And the real challenge is how do we detect those as soon as we possibly can? And when I was at ONDCP, I worked on these kinds of issues a lot. And especially this was when xylazine, the veterinary tranquilizer, was first being noticed. And the real challenge was how do you detect it as soon as you can? And how do you then decide whether you want to declare it officially an emerging threat? And if you do, how do you develop an action plan to address it? And we did all of that with xylazine at ONDCP. But I wanted to just touch base with you today on drug checking here in the state of New York. And we can check drugs with test strips. Everybody's familiar, I'm sure, with fentanyl or xylazine test strips. That's one possibility. Another is to look at the suitors data. And a third that I'll touch on now is to actually test drug samples to see what is in those. And those may come from someone who is using substances and gives a very small amount of the drug for it to be checked, or there's maybe a plastic bag or something that is found and there's residue of drug in it, and that can be tested as well. So on this slide, what you can see is there's an emerging drug checking program in the state of New York. The Fourier transform technology is more spread out throughout the state. a little easier to access and use. That's in yellow here. And then in purple are the confirmatory labs where the samples might have to be sent to a confirmatory lab to be absolutely sure what the result indicates. And if you want to learn more about this, we have information about the drug checking data on our website. The QR code is given here. And I just wanted to show a slide of results. And this is if someone is giving a very small sample of drugs to be tested, a question will be asked, what do you think is in the drugs? What do you think these drugs are? And if you look on the right-hand side, if the person says, I think this is cocaine, likely it is cocaine. 97% of the time, cocaine is there, it's present, and not as much in the way of other kinds of adulterants. There's some, but not as much. On the left-hand side of the slide, you see that if you ask, what do you think this is? And the person says that it's fentanyl, it can be lots of things. It's got about a 51% chance of including fentanyl, but a lot of other adulterants that you see here, a lot of cuts to try and make the drug go further, and maybe other substances like cocaine are present as well here too. So I think this is quite interesting because it really says if you think you've got cocaine, you probably do. If you think you've got fentanyl, then it may be one of quite a large number of things. And then this is a little bit more that you can find on our website about drug checking, taking a little deeper dive look at xylazine. It's gotten a lot of state and local attention over the last couple of years, and you can still see there's dips from time to time of how many samples contain xylazine, but still pretty present. And the last one is looking at medetomidine, which is another veterinary tranquilizer, even more powerful than xylazine, and that is been seen as well too. And certainly there's a presence of it in New York State. And this is just showing quickly, if you put the suitors data up versus the drug checking data, they tell you relatively complementary things, but sometimes a little different lens to look at the data. Like xylazine here is 20% in one data set, 40% in the other data set. So you can get a little bit different lens view depending on whether you're looking at suitors data or drug checking data. And then last couple of things just to touch base on. If we look at some more service delivery coverage, this is going back to the drug user health hubs. And just to say one more word about drug user health hubs, these largely contain syringe service programs, but also they go far beyond that. So they provide access as referrals to drug treatment, to medical and social services, to infectious disease services, to a wide variety of services. They try to be as comprehensive as they possibly can. Sometimes services are provided directly there, and sometimes it's through a complicated referral network. And since I'm speaking to you, Buffalo, today, just to say shout out to Josh Lynch and the Matters program, which is a really important referral system in the state. And I would have shown Matters slides, but I know you've heard presentations from him before, and just wanted to highlight the importance of Josh's work with the Matters network as well. So here on this slide, though, is taking that statistic that I mentioned earlier about how far away most of the population is in New York from Drug User Health Hub. And you can see in 2020 and 2023 what it looked like. There's still some geographic areas of the state, but about 90% of the population is within a half hour. So the dots are the sites themselves. 15-minute drive is in black. In purple is a 30-minute drive. So good coverage. It overlays pretty well with the number of fatal overdoses, but there's still important work to be done, important areas to try and achieve additional coverage as well, too. And also on this slide, just when we think about number of clients served, wanted to just present this because it gives a sense of the tens of thousands of people who have been served, unique persons who are served. But often the drug user health hubs, the person is coming back repeatedly for services. So it's in the hundreds of thousands of contacts if you look at that over time. So 66,800 unique people served. 537,000 or so number of contacts. So each person coming back several times, which is typical for this kind of service, which is important. And then this is just another data visualization of across the state where the unique clients who are being served, largely New York City, largely the southern tier, and then Western New York and the very eastern side, pretty well served as well too in terms of number of clients. So just wanted to say in a couple of minutes here, I will stop. Um, a word about naloxone. And this, I think, is important because if we look at that decline in fatal overdoses, there's a number of potential reasons why that may have occurred. I think, though, one of the theories that's always discussed is that naloxone has been utilized much more over the recent years and provides a way to addressing the lethality of the drug supply. And in this slide, there's many ways I could talk about the distribution of naloxone in the state. In this slide, I just wanted to present because we often think about naloxone as the number of units that are distributed, that are given away, and that's important. But it's also important to be able to have a system set up where you can keep track of the number of naloxone uses that are actually administered. So the product is actually used, not just distributed, but used. And you can see on the right side of the slide that in New York State in 24 and the first quarter of 25, how the number of naloxone administrations breaks out by community program, law enforcement, and then others like firefighters, other categories are unknown. And I think this is important because it gives us a sense of if Suitors is telling us that a fair amount of overdoses occurring in the home, in community settings, then we have to equip community members to be able to respond as much as possible. And we're starting to see that growth, I think, when we look at this administration data. But it's a useful way of us being able to keep track of whether or not that area of community-based naloxone distribution is going up over time. And it's certainly an area that one would want to continue to grow. And then in some ways on this second last slide here, I'm getting to Stu's question, and that is, so what about this year? Well, in the paper with Commissioner McDonald, the first part of this you've already seen. This was comparing 24 to 23 and how many lives, years of life, and economic were saved and the economic impact. But we also in the same paper said, well, 2025 seems like a really pivotal year. And three things could occur, one of which is you continue maybe the downward trajectory at the same percentage rate that we saw from 23 to 24. If that continued from 24 to 25, the second block of numbers is the impact that you would see if we could keep that up somehow. But what if we stagnate? What if the number of services are cut back on in some way and we see that the numbers are starting to flatten out? Well, then of course we wouldn't have that kind of impact. And for illustration, we put all zeros here. If 25 is exactly the same as 24, there wouldn't be additional lives saved, wouldn't be additional economic impact. And then we also sort of entertain the possibility of what if it didn't just stagnate, but there was a reversal of progress. What if we went in 2025 back to 23 levels? That's essentially like then taking the negative of everything that we saw between 23 and 24, of course. And instead of savings, it would be costing lives. And so I think we talk in the paper and in general a lot about 25 being a really pivotal year. Are we going to be able to continue this increase over time? Or is it going to stagnate? or is it going to be a reversal? And this is something we really want to be able to keep an eye on as we go through this year and as the new CDC data start to come out. And then the last data slide, information slide I just wanted to show was, in addition to the things I presented today, OASIS, another key state agency, of course, doing important work in this area, has some dashboards on their website. So I wanted to list the URL there, where you can break out some, especially the fatal overdose numbers in different ways. So wanted to give a shout out to the OASIS dashboards here. Also wanted to note that on DOH's website, we have literally dozens more metrics on opioid-related information. Gave two URLs that take you there. And then one thing that's not a New York State resource necessarily, but I just wanted to call your attention to is in my last job, I worked a lot also with colleagues at NHTSA, the National Highway Traffic Safety Administration, and ONDCP and NHTSA developed a national non-fatal overdose dashboard. And if you go to, and CDC also has some information on the non-fatal overdoses. The most quantitative information is probably here at this URL. And I just wanted to share it as well, because if you're interested in fatal, but also non-fatal overdoses, I think this is a resource that is potentially useful as well. So with that, thank you very much for your time and attention, and I will stop sharing and look forward to the discussion.
Dr. Clark, would you like to field any questions or?
I can start off with a question, and then I guess, Jill, in the past, have we just had people unmute themselves to ask questions?
I, Dr. Holtgrave, if you're okay with that, we can.
That's fine. Absolutely. Thank you.
Okay, my first question, without naming names and getting into it, I'm wondering, in your first part of your talk and just in your last slide, you mentioned CDC.
Yes.
In the current environment with the current administration, how do you see that impacting our ability to get that crucial data from CDC and how that's going to impact us going forward?
Yeah. Um, I, I guess I would say, so if you'll permit me, I answered a little bit more generally,
Hmm.
including, but not just limited to CDC. I think one of the things that Professor LaBelle and I've wrote about a little bit is trying to keep an eye on what are data sets that we're not seeing anymore. So the data set Dawn, which was a federal data set, which was really important for early warning. So the W for warning there, that is no longer available. And if you try to go to the Dawn website now, it tells you that it's not being offered anymore. So that was an important area for looking at emerging threats that we don't see. Then there's, I think, a category of where we know that there have been layoffs in some area and don't know what the ultimate impact is going to be. So there were reported a large number of layoffs related to the NISDA data set, the National Survey of Drug Use and Health. Um, uh, but it still seems to be ongoing as a data set, and I think only time will tell then of how, how much these layoffs will impact that specific data set. And then, I think some of the data, like the fatal overdose numbers for CDC, I think one good thing is there's enough people who work with those data sets. We sort of keep track of them. People have their own copies of them. People can take a look at them and also can kind of predict where the data is not only at, but where it was kind of expected to be. Is there something anomalous or something? And I would just refer you to Professor Nab Dasgupta from the University of North Carolina has a lab that is really focused on epidemiology and substance use and does super deep dives on not only analyzing the federal data from CDC on overdoses, but does it for all the states and then looks at patterns across all of the states. What would you expect? So I think Nab Dasgupta's website is really a very important one there as well to look at.
So do you think, just to follow up, do you think this is really going to turn into a grassroots kind of effort to fill the voids?
Yeah, I think, it's important that we take the data from federal sources where we have it. I think it's also important to, keep backup copies as time goes on, like the Dawn data set that's not available there now, to be able to have copies to be able to fill in the gaps. And I would say, and this is not a comment about the current administration or anything. I think as scientists, we're all completely committed to triangulation of results and either replication of results, triangulation of methods. And I think that's always true. When I see something that's of interest in substance use data and HIV data or so on, I want to know what other lenses we can look at that same phenomenon, and do we get the same story or different stories as we use different lenses? So I think that is something that we should be doing as scientists as well too at the same time.
Great, thank you. Uh, is there someone in the audience that had a question? You can just unmute yourself while people are thinking of it. I have another question.
Please, yes.
Um, so you pointed out a lot of data on polysubstance fatalities. What's the current thinking of what's driving that from a toxicology kind of perspective? Are they able to make inferences based on, absolute drug levels in the fatalities as what is driving these?
Yeah, no, it's a really good question, and I think your background, Dr. Clark, is probably better able to answer the question. So I'll turn the question back to you as well too for any comments that you have. I think a couple of things. One of which is I'm struck by, for instance, the drug checking data, where if you think you have fentanyl, you may have a wide variety of other things. So I think one driver is you may be preparing yourself to use an opioid and thinking about that, but there's a stimulant there you didn't know about that you had, or there's an adulterant there that you didn't know that you had. Um, I also think that an important issue too is when we think about responding to an overdose, when we saw, so xylazine is not an opioid. So specifically, naloxone wouldn't work on the xylazine, but because xylazine is generally an adulterant of fentanyl, you definitely want to still use naloxone, of course, because you're trying to address the opioid part. But xylazine would also suggest that you should be even more concerned about assisted breathing, making sure that you're staying with the person, not only that they're being revived, but they are awake over time, that their breathing is their airway is protected. So I think the polysubstance use makes it a little bit more complicated in terms of how we're responding. But I also worry a lot about people getting lost. Oh, well, a number of things are being used, so we shouldn't use naloxone anymore. Definitely not that message. Right? We want to keep using naloxone for sure. And so anyway, those are just a couple of thoughts. I don't know, Sue, if you have other thoughts on this issue, given your background.
No, I'm gonna leave it up. We do have a question in the chat, so I'm gonna
Okay.
stop monopolizing. Uh, so there was a question in the chat. One is, do you have any advice on how students can get more involved in addressing the opioid epidemic?
Yes, no, it's a great question. And I think looking for well, a number of things, one of which is given the amazing array of researchers who are doing substance use related work at University of Buffalo, there's a great number of people to make contact with. And I just wanted to say, like even in the last couple of days, I reminded myself I did search on University of Buffalo and research in substance use, and dozens of amazing faculty came up, amazing research programs. So I think getting involved in some of those laboratories is really important locally. I think the health department, Erie County, Dr. Burstein is great, and looking for internship or other opportunities with the Erie County Health Department is key. And then also statewide as well too. There's sometimes internships that are available on our website. And I would say too, if anyone's on the session today and you don't immediately find what you're looking for at University of Buffalo, Erie County Health Department, please feel free to shoot me an email, and I would be glad to receive that from you, and happy to help try and network as well too. So those are just the first couple of thoughts. But thank you for your interest. That's great.
Great, thank
And
you.
thank you, Josh, for your very kind note. Thanks, Josh.
Dr. Elkin.
So thank you for the very informative talk. My name is Peter Elkin. I'm the chair of the Department of Biomedical Informatics here at UB. We do a fair amount of work in opioid, um, some of the papers you may have seen, but there are a couple of trends that I'd like your opinion on, and then I wanted to make you aware of something that we have here that you didn't talk about. So the one of the trends that we looked at was using buprenorphine for acute pain, and and that it may be that in the future we don't use other narcotics for post-surgical and other kinds of acute pain because it actually worked very, very well and was safer and led it to less opioid being on the street. As you probably know, about half the problem are injectables, and about half the problem, at least in our region in Western New York, are being prescribed by physicians. I'm a internal medicine physician as well, and so I think that these kind of, naloxone's one approach, but I think also we need to change medicine and prescribing practices in order to probably improve the availability of these drugs to people so that we have it harder for people to overdose. And then using safer things like buprenorphine, I think, is a good thing. And then I'll just make one 30-second commercial interruption. We have a database that we built through NIH funding with Oasis, which has the Medicaid data and the Oasis data merged together. And we've published on the database pretty extensively. And we think if you could comment on the role of these kind of databases in the armamentarium that we have in order to fight the opioid epidemic, I'd be honored to hear it.
No, thank you so much. Great on both accounts. I appreciate it. And I think on the issue of using buprenorphine and acute pain, I would love to follow up with you on that if that's okay, because Dr. Sharon Stancliffe here has been working on, we have a lot of resources around prescribing on the website, but how can we take the next steps forward in terms of proper prescribing of opioids when absolutely necessary, alternative to opioids, and then non-prescription alternatives to pain management. So this is a really important area for us. So if you don't mind, I'll reach out, Dr. Alkin.
No, that'd be great. I'd look forward to talking to you more about it, and I'd love to share our papers.
No, that's great. And just to say to your point about the work with Oasis and the kinds of data sets, including Medicaid that you were talking about, really important to look at those service delivery systems, payment mechanisms, and now especially given the changes in the federal landscape of what might be happening in those payment systems, even more acutely important. So I just wanted to appreciate that, and I'd love to continue to learn more about that as well too.
Oh, I'd love to be able to talk your ear off a little bit about it and what we'd like to do in the future. Ken Leonard, who I'm sure you know, is my co-PI on this. So yeah, there's a lot of good work being done.
Excellent.
Thank
Thank
you.
you very much.
Jill, do we have room for one more question?
I think so.
Okay, so I'm going to encourage David Hertzberg to unmute and ask his question. It's also a plug that David Hertzberg will be presenting in this series this semester as well. So David.
Yeah. Hi, sorry, I sent it to you by text chat because I had to step away for a minute. I was worried that I was asking a question that you had already answered. I was just wondering whether you're able to analyze relationally between databases to answer questions about, for example, how a particular intervention, such as people who've received a prescription for buprenorphine, whether that has an impact on a particular outcome, such as fatal overdose or ER visits. Can they can they work that interoperability like that, or are they have such different bases that that's challenging?
Yeah, well, it's a great question. Thank you. It's so definitely challenging, but also an area that we're working on. So one of our offices the Office of Science, and then there's a team in the Office of Drug User Health, are really interested in exactly the question that you're talking about. And I think one of the kinds of things we're talking about is, are there some of the larger payment systems, vital record systems, others that we have that we could start to put together in some way? And then, I think also figuring out ways to do that. I did a lot of HIV work over the years, and a lot of the issue was how to use Soundex and other codes. So even if you didn't want to match on name necessarily, but you wanted to have enough confidence that you were probably had a unique individual in that data set. So there's a discussion about what are some of those approaches as well too. So this is another area I'd love to be able, Dr. Hertzberg, to follow up with you further on this and see what you all have in mind. And if you don't mind, I'd love to link you to the people here who are talking about this interoperability question as well too, because it's very much on the plate.
Okay, I'd like to thank Dr. Holtgrave for his precious time and sharing with us. And what I'd like to just make one comment here at the end of the discussion. I think we've just already established 2 collaborations. And I think that's probably the best outcome for these kind of seminars and discussions that we have. So really want to thank Dr. Holtgrave for joining us today.
Thank you so much for having me. It's been a great pleasure. Look forward to following up.